University. Please welcome Ajay.
Thank you, Melissa, for that kind introduction. You didn't have to mention 30 years twice, but that's okay. And welcome everyone to today's Legislative Summit and to this panel where we'd like to discuss the impact of nursing care on outcomes and healthcare costs, which is instrumental for creating an equitable reimbursement rate. Please help me in welcoming our panel, who are all commissioners of CNR. Karen Grimley, PhD, Chief Nurse Executive for a major academic medical center and Assistant Dean for the School of Nursing in California, where she has expertise in nursing workforce strategy, given her view from the classroom to the bedside. P.K. Scheerle, nurse leader and trailblazing entrepreneur, founder of American Nursing Services, Inc., from which she successfully exited, and CEO Emeritus and board member of Gifted Healthcare, with the goal of transforming healthcare and the work of nurses. And I think you recognized well over 1,000 nurses now through your program. Gifted nurse. Paul Coyne, formerly of Goldman Sachs and current Senior Vice President of Patient Care Services and Chief Nurse Executive at the Hospital for Special Surgery, giving him unique insights into clinical practice, finance, and technology that allows both Beckers and Business Insiders to name him an influential leader under 40. Welcome to the panel. And to the audience, we want this to be as interactive as possible, so I'll start with some questions. I hope I don't have to get to question number 2. Please think of questions of your own. And if we say anything wrong, call us out, please. Let's get started. So for my first and hopefully last question, I'll just state this out and give you all a chance to respond. But given the mounting evidence linking nurse staffing levels and patient outcomes with specific policy or regulatory changes, do you believe are necessary to ensure adequate nurse staffing in healthcare settings and prevent adverse events, readmissions, and compromised care quality?
I already talked to next speaker.
Okay, Paul. I think being in California, I already have got a layer of what I'm going to call CNO protection. And I am not a proponent of ratios by any means, but with ratios, I have got a floor that my executive suite has to honor. Unfortunately, nurses are not widgets, we are not a commodity. And that's essentially what ratios does to nurses. What we have to do is really understand how do you show the value. And the value comes with recognizing the acuity of the patient and what it takes to bring that nurse with the right experience to that bedside. So that said, regulations that would be helpful to me would be some kind of acknowledgement, maybe not a regulation, but an acknowledgement about what that nurse does mean to the bedside. The research shows everything. It shows reduced length of stay. It shows things that are very measurable to a CFO's mindset. What we never talk about, though, is the reduction in the risk of death. And we're very humble. We don't brag about that, but nurses play an instrumental part in reducing the incidence of death, especially in acute care hospitals. So, and for all of you who don't know this, staying in the hospital even an hour longer than you need to increases your risk of a medical error of some sort. So what nurses do to make sure you get out on time is life-saving, even if it's just wheeling you to the door. So I think those are things that would be important to me, is to call out what that value is in dollars and cents.
I would agree with that and just twist a little bit to say, if you think about the nurses in the room, which one of us would let someone we absolutely love go to the hospital without us? No one raises their hand. That is the biggest crisis in American healthcare. Everything we are here to do today is about that. There's only 2 reasons to spend the night in the hospital. One is technology, and the other is nursing care. So as we begin this journey of 40 years, rekindled today, it is wildly important for everyone's family members, everyone's relative, everyone's dry cleaning lady, to know why we wouldn't let someone we love go to the hospital without us. And I think that's really critical, and we're talking about legislating and policy, but at the core, this work is born of this need to not be afraid to go to the hospital.
Just add one more point on the cost avoidance. I think, the reason why I'm here today and why we're all here, as soon as you start, every argument that we have to start in nursing is to talk about cost avoidance. If you add more nurses, you won't lose as much money because there will be less adverse events, or there'll be less, which is all true, but it just doesn't get the same as making money. People like to hear more how they make money than not losing money. That's why it needs to change. And I think that the policy that we're all advocating for is that switch.
The switch from a cost avoidance to a revenue maximization strategy?
Yeah.
That's an interesting point, because you're right that I think in healthcare in America we have a very mature system. We've been thinking of cost reduction for a long time. We say that the cost spending curve is on an unsustainable path, but we don't really necessarily talk about how to address that by increasing revenues. Do we think that potentially nursing is one of the primary ways where we can affect revenue?
I think so. I think, I have a nursing team that's a nurse-led interprofessional team. It's born of nursing that aims at readmissions. We've dropped the readmission rate in our hospital by almost 4.5% over the last several years. And when you think about the savings that brings into an organization, we have to teach finance officers to look in new and different places for those savings and for that revenue. Because the penalties associated with readmissions are there. They may not be as robust as they could be, but they're there. So we're contributing every day with no recognition, except for how much we cost.
Any questions from the audience before I go to question number 2?
Breaking his heart.
I know, this is a hard question. Nobody wants to take it on the panel. We're hoping that you can. All right, that's all right. We'll go. We'll go to PK with this one. Numerous studies, PK, have demonstrated the economic burden of adverse events and readmissions resulting from inadequate nurse staffing. How can we better translate this data into actionable strategies for healthcare organizations to prioritize investments in nursing care and improve financial performance?
Thank you for the question. It's important to understand and to think about what the patient needs, wants, what the family needs, wants first. And I'm annoyed with Mayo Clinic for the decision they made on the bill, but the needs of the patient must come. The needs of the patient must come first. And if you think about gaining revenue and revenues, repeated revenue and serial revenue, it's by being a place or a business where people admire what they get when they go to buy their care, in this case. But if you think about, we both are go look for a blue dress. We both find 2 blue dresses we like. One's $60, one's $600. It's a special occasion. We will pay for the dress that is a special occasion dress, willingly. The problem comes in healthcare and nursing, where the patient doesn't know which is the $600 dress and which is the $60 dress. And the patient's family doesn't come in and say to the nurse, how many patients do you have today? Or when's the last time you had a day off? Or how many 16s did you work last week? And the nurses feel like they have to do this to have their job be secure. And the result, of course, is bad care and unintended bad care. But if you talk to your legislators and you talk to our politicians and they trust you, they admit they're scared to go to the hospital. So everyone knows it needs to be fixed. And the way to fix it is to have people want more of what you've got, the way you've got it, what you want, when you want it, where you want it, how you want it. Better, faster, cheaper, but most importantly, better. And so it's not about the nurse as much as it is about the patient and the family, and what is a fair expectation for healthcare organizations to meet as a minimum or adequate standard for that care in the hospital.
You want to add something on that, Paul?
Yeah, repeat the last part of that question again one more time, I'm sorry.
Certainly. How can we better translate this data into actionable strategies for healthcare organizations to prioritize investments?
So I think the issue is that the policy gets made and then either the fine or the reward, either side to the hospital, happens. But there's no mechanism to see if nursing either benefited or suffered as a result of that money. So for example, if a hospital gets a better rate with the payer for having high quality outcomes, or they're fined because they don't, in either scenario, the money goes to the hospital, but there's no mechanism to see if that additional money goes to nursing to continue the good outcomes or hurt nursing to make even worse outcomes. It's just sort of a hit to the hospital's bottom line without real way of knowing if it impacted the most important thing that has to do with patient safety, which is the nurses. So I think the data on the follow-up on the data of these programs of how money is being given or taken from hospitals isn't really going to the level of did it get to nursing in the hospital, it's just going, did it get to the hospital?
So in that scenario, then there's also the possibility that the hospital did well, and it doesn't know why it did well, and it can't replicate that across its patient population or across its network.
Absolutely.
Because they can't see it, right? So, and I guess speaking as a nursing executive across a large system, the burden that's put on nursing is pretty significant, especially for that chief nurse. Because one of the things that happens is for you to advocate for that group to make sure you have the right patient-centered care, because PK, you're right. If you build it around the patient, you're going to build the right resources at the right time, and the cost will be right too. And for a nursing executive in this country right now to do that, it is brutal. Because every year when you face your budget season, it's what are you going to cut? I don't know, you got a lot. What do you got? And do we really know? I mean, based on what you heard today, we know that nursing makes a significant difference in outcomes. However, we can't measure it. And we were talking earlier today about transparency and how can we have any transparency if we're invisible? So it's one of those things, how do we create a mechanism that reflects or shows what nursing does in the course of that patient's stay or that day or that procedure or that visit? And that's where we have an obligation. So, and then protecting your staff. How do you protect the nurses who need the break, who didn't get their vacation or didn't get this and that? And then you're chastised for building a float pool of 600 nurses so that you can do that. And then, is that too many? Well, nobody knows. So there's a whole conundrum that follows this inability to see what nursing brings to the table. And so I think that the work that's being done with this commission and what we can do in the future is going to be significant with all of your help.
Karen, I think what you said is exactly right. And you highlight the idea that the public, the patient, the families have no idea. They ask their car mechanic more questions about how many chassis he's done or how many rear ends he's done, rather than ask how many of these surgeries have you done in the last 3 months? You know, or how many patients do you recover in your 8 hours in the PACU? Nobody knows, and if the patients knew, they'd be up in arms and they would do the work we're trying to do, because when nursing is reimbursed properly, the backbone of healthcare, the backbone of care in almost all settings, it changes what the expectation is and the money will follow. Doing well by doing good always happens, always. And so nursing has to find a way for the public to be as outraged. You know, Greek philosopher was once asked, when will justice come? And the answer was, justice will come when those who are not injured are as appalled as those who are. And we are, as nurses, the silent ones in this, unfortunately, for many years, 44 years of my life as a nurse. Instead of saying, we've done plenty of saying we're not going to take it, but we should and can be saying through legislation, the public is not going to take it. And that's where I think it really comes actionable and rubber meets the road.
We have a question in the back.
So hi, thank you for this great conversation today. I'm a policy wonk, so I'm already kind of going to legislation, implementation, regulation, and that's where my head goes. So as we talk about the various payment models that we talked about, we also talked about the human touch as well as the professional services that our nurses provide. So I would like to hear how each one of you defines value.
Sorry?
Value.
Defines an outcome.
How do we define value of nursing? And how do we get to a baseline of that definition by which we can better quantify better reimbursement based on value?
I'll take a stab at this. I think everyone would vote differently about the value question, which is part of the problem. But the simple, I'm a simple person, my mind immediately thought, what a great question. And the value is how well I am when you're done with me, how I feel while you're getting me well, how my family feels while you're getting me well, and whether I had dignity and respect and kindness and compassion and expert, experienced care by a happy person. That's a big bundle, but at the end of the day, as human beings, that's what we want. And that's what nursing wants to give. So I see that as the value proposition, which is impossible to meet today. Every time I do grand rounds anywhere, it's crushing.
I think that, I think the way that I measure value is, this is going to sound really tacky, but what I've had to do to make my claim and to help people build the nursing organizations that I've had the privilege of working with, I have to take existing variables that people respect and recognize in the industry, and that's how I drive change. I take the readmission rate, I take the length of stay, I take the hospital-acquired conditions, even though they call them, nursing indicators. But if I'm going to be responsible for NSIs, then I'm going to be responsible for NSIs and nurse engagement. So that's the balance of the experience between the staff, the patient experience, and then also how am I performing around metrics that are recognized as contributing to better outcomes in the profession and in the industry. So that's my scorecard. And I do think, while I am a proponent of nursing excellence, the challenges of maintaining an ANCC magnet designation are vast. And I think those indicators should be wrapped into this scorecard in a way that people recognize besides, a couple of points on US News and World Report. Because that's pretty much how a lot of industry leaders rack up at ANCC. So how's it going to help me with my report score? So, which is unfortunately how many of the organizations in the nation measure where they're going to go for healthcare these days.
Just to add, the reason I paused and went last, I was trying to go back to my business school books and picture the equation. I think it's like value of outcomes over cost equals value. Is that right? I think that's plus. Yeah, so I think in the free market, normally cost will increase until the outcome is desired, or the good, but but in healthcare, because of the problem that we're all talking about today, the ratio's wrong, because the value of the nurse is recognized on the right, but the outcome and the cost don't necessarily go to nursing, like we've talked about in terms of the policies. And so then you end up with a scenario where everyone says, oh, nurses are extremely valuable, but the other side of the equation is kind of messed up. So I think it means the same exact thing to me as it does in business. More nurses lead to better outcomes, lead to better value, except we don't have that. We have a system that doesn't allow for the natural equation of what is valuable to be allowed to exist.
This is not, yeah, I applaud you too. This is not a thing for today, but what Paul just said made me think. Most nurses get paid on seniority, and I have always been a believer in my career in building companies of nurses to pay the nurse based on the nurse. And that happens naturally in almost all other businesses. We all know in our institutions who our rock stars are. They generally don't get paid a whole lot more than the bedwetters. It's not okay. This isn't a today discussion.
Right.
But it's a
let me ask you
big
to
part of
pause there,
our
because we have a
professional
question in
problem.
the very back by the TV screen.
Hi, my name's Betsy, I'm with the University of Vermont Medical Center. One of the things that you were talking about sort of the future of this work and sort of how do we ensure that this money then gets reinvested back into nursing, and often that leads me to think about governance. And so I'm curious, the conditions of participation, from decades ago, often have standards that sort of need to have physicians accountable to the board of directors, where nursing services is just that, services. And so, I'm thinking about how changes within nursing reimbursement can also help facilitate nurses' seat at the boardroom table, how we can have parity within representation with physicians to ensure that, we are at the board table making those strategic, financial, and outcome-driven decisions. And if you could just weigh in on, those are what actually drive, where this treatment from the organization is going and patient outcomes and cost of care. So just curious on the panels as well.
I believe less than 1% of hospitals in America have an RN on the board.
Ajay.
Well, we are the top 1%. We do have nurse representation on my board at Holy Cross and our Mission and Population Health Committee, and we're going through a merger, and the new merged board will also have an RN on the board. But I agree. I think it's very important that we have direct representation from all aspects of healthcare delivery, so that the board can truly manage and strategically advise healthcare delivery.
I'm just curious, I think there is a lack of nursing representation in terms of parity with physician representation. Oftentimes, I was the chief nurse, I was the only nurse in the room, there were 8 physicians. When I think about how decisions were made at the board table, very rarely were they swayed by one nurse versus 8 physicians. So I'm curious how this model can help bring nurses to the board table.
Right now, to those board members, nursing is a cost center. It doesn't create value, and it doesn't change their ability to be profitable or famous.
And what has to happen, Beth, and you said it right, nursing is a service. It's a complex service. It is not task-based. And the thing is that when you look at how people, because they don't know the why behind nursing, they discount the things we do as just that, as a task. The person who does an assessment, I think it was mentioned earlier today, goes in to administer pain medication. They're doing an assessment and an intervention. They're not just giving a tab of Dilaudid. So those are the kinds of things you have to think about. It's what that person's bringing with their intervention that makes the difference. And people will invest in a service, they will cut a cost.
That's
Well
a
said.
great answer.
I'd also like to add to the idea that nursing is a cost center. If you flip that, if they become revenue generative, you will have nurses on the board of the hospital. Because
That's what I'm talking
you will
about.
have, all-star chief nursing officers and et cetera who are bringing in revenue and improving. And if we tie the reimbursement to outcomes and so that such that nurses are not only getting paid for their services, but we're showing the outcomes associated with better nursing care. You will have better care, and you will have better nursing representation, and knock-on effects of this.
I think we may need to pause on that a second, because I'm thinking of my board. I don't think that we have constituted a board regarding revenue generation, right? As we talked about earlier, right now the focus has been for the past decade or so on cost minimization. So our board is represented in areas where we have costs, right? Real estate is a big cost for us. We have a real estate lawyer on the board. That's the kind of model we've been using for board composition. So I think we have to get the industry to think of revenue generation, and then things will follow, right? How do we get more people representing on the board who know how to make revenue generation? But we have 1 minute left, plus the time we're going to bother Melissa by staying up here. So Linda to give us the very last question of the day.
That's a lot of pressure. Thank you, everyone. So just a thought, just in all of this discussion, I think part of the work that could be valuable to this mission of this commission is to really engage chief nurses in the idea of not just how do we create a revenue stream to nurses, but how do you lay the foundation within your organization to be ready for that support, to be ready for that dialogue? And Karen, what you said, what I did at Mount Sinai's, HAPIs and nursing sensitive indicators, I didn't just report the outcome, the number, I reported the dollars. So there isn't the structure for that everywhere, and I think many nurse leaders don't think about it that way. We think about ourselves as a cost center. We have to think of ourselves as a revenue center, because otherwise we won't be able to change the minds of other people. And that's going to be really important. That convincing is going to make a difference.
That's a good point. Well, Rebecca said we have to stop. So. Thank you, everyone, for your participation, your questions. Thank you for the time.